So can we now settle and start our session, the second session? I hope you had a good lunch, with a lot of beef and vegetable and dessert, and which will not make us doze off. The morning session was good. We listened to a politician and learned quite a few things. Well, distinguished delegates, we'll now take up agenda item number 5, which is on the work of WHO in the Africa region 2016 to 2017. And the appropriate document is prescribed as AFR/RC 67/2. But it is really in these two documents, these two big documents here. Now, the person to go through the work of the WHO in the Africa region will be none other than our regional director, Dr. Tshidi Moeti, who will present her report. So I'd like to ask Dr. Moeti to come and give us and take the floor. Dr. Moeti.
Thank you very much, Chair, and good afternoon, honorable ministers, delegates, colleagues, partners. It's my pleasure to present on behalf of the Secretariat this report of the work of WHO in the Africa region for 2016-2017, and it covers the work in the first 18 months from January 2016 to about August 2017 of the second biennium of the 12th WHO General Program of Work. And our work is organized in 6 categories, which are in communicable diseases, non-communicable diseases, in promoting health through the life course, health systems, WHO Health Emergencies Program, and finally, corporate services and enabling functions which support the delivery in these program areas. So this report highlights the progress that has been made jointly by member states to improve health outcomes with the support of the WHO Secretariat in the region. Next slide. I do hope that the slides are legible from everywhere around the room, because we have the luxury of a very large room. So how the report is structured. First, it's organized in 4 sections. There is a brief introductory message from the regional director. Then there is a summary of the program budget, how the funding was allocated and utilized, and where we are with budget utilization. And then we highlight the significant achievements by 6 categories, which I've listed for you. And you will find more detail in the reports that the chair was referring to. And then there's a conclusion and a way forward. Next slide, please. So essentially, what we understand is that with the Sustainable Development Goals, which were recently adopted by all the countries, we really have new opportunities to advance health and to advance specifically universal health coverage. Having learned from the era of the Millennium Development Goals, there is rather more emphasis, for example, on equity. I think there's a very explicit reference to resilient, robust health systems that are able to deliver health services to all people, something which was not really explicitly articulated in the Millennium Development Goals. And there is a great emphasis, it was said this morning, particularly by the Director General, that the Sustainable Development Goals are mutually supportive and therefore give us opportunities to address the social determinants of health and to work with other sectors for the benefit of health, and also to see how health can contribute to to development in other areas. We recognize that we work in a complex and multifaceted context. I won't go into the details of the disease burden, but we have what we sometimes call the double or even the triple burden of communicable diseases, of course, also high rates of maternal and child mortality, non-communicable diseases rapidly evolving, it was already mentioned, and then we have other factors that are relevant to health, so social and economic determinants, climate change particularly, and the geopolitical context, which is shifting in such ways that there is much more emphasis now, for example, on domestic allocation for health development. I think we are observing that these are the trends. And of course, we recognize that although much work has been done to try to improve the health systems in the region, there are still major gaps in terms of the capacity of our health systems. If we look at the different building blocks of a functioning health systems, there is much that we need to cover still. But still, we recognize that there are some opportunities as well. Our region has taken on in a very big way the use of digital technology in all spheres of development. If we look at agriculture, different areas of development, Africa's young people are definitely embracing the use of technology for all sorts of purposes. This is an opportunity for the work that we need to do in health. There is also, as I mentioned earlier, on a growing private sector engagement in health, which is an opportunity for not only additional financing, but other broader skills, experiences, ways of working that can all potentially contribute to universal health coverage. We speak very often in our region about the demographic dividend. We have a burgeoning young population, which is an opportunity but can also be a challenge for us to address. We've seen very much the capacity, the energy, the innovation of this young population as an asset that can be leveraged for work on health. And we're very pleased, for example, and we are increasingly engaging in Afro with young people, young professionals, young people who work in other sectors who are very energetic advocates for health. And we think that this can only benefit our collective work. We are implementing our transformation agenda. It continues to inform and to guide all our actions in the region, with very much of a focus on delivering results, monitoring for results, and I think I'll just echo what the DG said earlier on. We have a range of areas in which we're working, but have particularly prioritized the public health emergencies, so health security, and universal health coverage through health system strengthening, where we can deliver for communicable diseases, non-communicable diseases, reducing maternal and child mortality and other areas on which we've already been working. And our focus as WHO, your secretariat, is to work with you in providing policy advice, in helping to strengthen leadership and service delivery capacity, in generating data so that your actions can be taken based on evidence, in promoting partnership, recognizing that neither WHO nor governments or ministries of health can do this work on our own. And we use this framework as the guiding principles around which we are working. Next slide. As far as the program budget is concerned for this biennium, so we're reporting on the period, as I said, which will end in about August. So the budget report is up to June 2017. So our region had an approved allocation of $1.1623 billion at the beginning of the biennium, which is 27% of the global budget of WHO. By June 2017, this total allocated budget for the region had been revised upwards. That is, we had observed the need to mobilize additional resources for certain specific needs. It had been increased to 1.679 billion, and mainly this was additional funding in the areas of polio and OCR, I don't have a pointer here, but it's the fourth line if you look on the left. So this is the main area in which additional funding was approved and the budget ceiling was increased. This was funding partly to continue the response to the Ebola outbreak, especially some of the health systems related recovery in the affected countries, and also to work on outbreaks and polio eradication. We note that the implementation rate for this budget up to now on average is 76% of the funds available. So we have a few months left in the biennium in which we need to accelerate and implement all the budget that we have available. Next slide, please. And here I think I really probably need to apologize for the fact that for some people right at the back it might be difficult to see the figures in this slide. So this slide refers to what we call the base program. So it does not include polio and OCR. It does not include funding for outbreaks and emergencies, and which are covered in fact in category 12. So what have we seen as trends in the implementation of the budget, now broken down by categories? First of all, we recognize, and this was discussed very much at the governing bodies, at the executive board, and at the World Health Assembly, that our budget in structure continues to be sourced through two sources. One, flexible funds, that is the assessed contributions, which constitute about 18% of the budget, and then specified voluntary contributions, which are earmarked, which is about 82% of the budget. And one concern that was noted during this biennium was that what we call core voluntary contributions, that is voluntary contributions that are flexible, contributed by some of the donors, have reduced in this biennium. So this is a signal that the flexibility of our funding is becoming even further constrained, or was more constrained in this biennium than was the case in the past. I'd also like to highlight, since we are about to embark on developing the program budget for the next biennium, that we notice that in comparison to other WHO regions and headquarters, our region has the highest average number of outputs per budget center, meaning we select from a large number of programs and we undertake to deliver many outputs. This, of course, is a challenge because it implies that our budget is distributed over many activities and outputs spread rather thin, and it constitutes a challenge in terms of how to manage the activities, how to focus, how to achieve some results in specific areas. And it underlines the need for us to put more emphasis on prioritizing as we are going to be developing the program budget for the coming biennium, being more selective in what we set out to deliver, acknowledging that it's not only WHO that is going to provide support in a number of areas. And if we have a critical mass of resources targeting certain deliverables, perhaps we stand a better chance of being able to actually deliver the results. We've put in place certain mechanisms to try to improve the budget monitoring and reporting, develop some new tools so that our budget centers are more closely keeping an eye on how we're doing in implementing what we promised to implement and in managing the funds, enabling us then at the end of the biennium to be able to, one, have delivered the results that we set out to deliver, and two, to be able to better link those to the resources that we are managing. We recognize the need to, I'd just like to say also that we continue to note that not all the categories are equally funded. And I'd just like to highlight the issue of non-communicable diseases and to some extent health systems as being two categories which are relatively underfunded, particularly non-communicable diseases. And this also implies that there is need for us to broaden the resource base for our programs in the region, to undertake much more resource mobilization within the overall framework of global fundraising for our work in the region, targeting the private sector, philanthropies within the region, so as to be able to broaden the base of resources. So what have been some of the key achievements among different programs? Next slide, please. So just starting with communicable diseases. Next slide. I'd like to highlight a few achievements. First, as you are aware, WHO introduced the Treat All recommendations in 2016, and we are very pleased that they have been rapidly adopted by 30 countries so far and are being implemented, meaning that we are expanding rather rapidly the coverage of ART. It's allowing for prompt uptake of antiretroviral therapy among people with HIV, regardless of their CD4 count. And ART has reached over 13.8 million people in the region by the end of 2016, a coverage of 54%. So although this shows significant progress, we recognize that more than 40% of people who need access to treatment still don't get it. It's also very encouraging to note that the number of people dying from HIV-related causes declined from 800,000 in 2015 to about 720,000 estimated in 2016. This is work to which we have contributed as WHO. Of course, much of the funding came from other sources, from the Global Fund, from bilateral, the big bilateral initiatives on HIV, from domestic resources, but WHO played a significant role in providing technical support to achieve this. There are some encouraging findings in HIV-TB co-infection as shown
going to find yourself doing
in
any
the
kind
graph.
of a business.
If you look at those bars in blue, they show the trend in the percentage in TB patients, new and retreated, who are recorded as HIV positive. And we see that this peaked in 2011 and is showing a leveling down and even a decrease going towards 2015.
If you were not fornicating,
secondly,
you should have been
we see a rise, the graph in red of the percentage of HIV positive TB patients who are started or continued on antiretroviral therapy.
it affects your material world,
the percentage started and continued on cotrimoxazole preventive therapy. The green graph has increased at a slower rate.
So
however,
even a man of God who is preaching the word and committing adultery,
most important, we are aware that
what you see him doing,
multi-drug resistant TB is a growing problem globally, but particularly also in the region. And it's very expensive to treat. This is one of the key issues that we need to pay much more attention to.
If you commit adultery, even as a woman of God or even as a man of God,
in Moscow
it will
later on
reflect.
in this year, at which this and
You
other
deliver
aspects
a
of
powerful
tuberculosis are
sermon.
going to be
It is only the sermon that is
discussed.
powerful, but you're not powerful
We
yourself.
worked with 11 countries to generate
People, they look at
evidence
you, you
on the
are
effectiveness
lightweight.
of a short treatment regimen for MDR-TB.
There is
And
no
this led to
presence on
WHO
you.
recommendations being revised to provide for shorter
You are
treatment
not
for
failed.
uncomplicated MDR-TB, offering hope. we
Why?
think,
Because
for
you have now
thousands
become a
more
vessel,
people
of course.
who can
You are
complete
a
the
vessel.
treatment
God is still
in a
using you,
shorter
but there is no
time
honor.
than had been before. So although these
Do you
are
know
areas
there
that
are
are
people like that when they step
greatly
into
challenging because
any
of the huge
place,
disease burden
without
in the region,
them having
there are
to say
glimmers
anything,
of
you
hope
can
in
still
some of the
feel they are
strategies being
here.
adopted, but also the indication that there remains much more to do in the region. Next
There is a
slide, please.
presence that you carry when you set
We're very pleased
yourself
to
aside
announce
for the good work
that
of the Master.
in
And
November
page
2016,
yourself
the world's first ever
and
malaria
flee
vaccine
from
is being
fornication
piloted in a number of
adultery.
countries in the African region.
Why
The
should you
RTSS vaccine
sacrifice?
has
Tell
shown,
me
has been
one
shown
thing,
to
some
provide
of you
partial
here. Why
protection
do you
against
sacrifice
Plasmodium
yourself?
falciparum in children, and will of course need to be used in combination with
At
other
such
malaria
early stages
control and
of a
prevention
relationship.
interventions. So this vaccine is being
Such
piloted.
sacrifices
The preparation for this
are
pilot
only
is being carried out
after
in 3
marriage.
countries in the region: Kenya, Malawi, and
Why
and Ghana.
should you die for him?
In the area of neglected
Why should
tropical
you die
diseases,
for her?
as I said earlier, we have made
Who is
some
he?
progress
He's not known,
working
not
through our
registered.
new program
not
called
recognized
ESPEN,
by God,
which relies much more
why
heavily on
should
the
you
capacity
go
of
all
national
the way
programs and
sacrificing for such a
collaboration
person
with partners
who
are
is not
implementing partners
married
on the
to
ground.
you?
This is a small, lean and mean WHO project whose role is mainly facilitatory and supportive. The region, through the work of our NTD program, made significant progress in mapping NTDs in the region. So we've had a mapping project in which we have mapped PC-NTD gaps in all 47 member states, and we have produced the first baseline endemicity atlas of the 5 PC-NTDs that I mentioned this morning: onchocerciasis, lymphatic filariasis, schisto, soil treatment, soil-transmitted helminthiasis, and trachoma. A portal is now available for member states and partners to use, and this is a key tool that can be used for decision-making by the governments, by the partners, on, for example, whether to continue or whether to stop MDA, multiple drug administration, and whether to even start treatment. So we think this is a significant contribution to the work that all NTD stakeholders are carrying out in NTDs. I already explained earlier this morning that ESPEN, for example, facilitated access to mass drug administration for millions of people. But most importantly, we worked with the pharmaceutical companies that are providing for free, donating this medication, and the national programs, and were able to track and recover 132 million tablets that were previously unaccounted, meaning drugs are donated, they get distributed within national systems, they don't get used, and our program was able to work with partners to track some of these, which will hopefully save some of the costs of providing treatment for NTDs. Next slide, please. Category 2 is about non-communicable diseases. As I said, this is an area which is emerging very fast. This has been recognized by member states, including at the level of the United Nations. But we find that the level of resourcing and the scale of programs is lagging behind the evolution of NCDs as a public health problem in the region. So there have been great efforts to carry out what we call STEP surveys. These are risk factor surveys to start to understand what is going on in countries as far as the risks for people to have NCDs are concerned. We managed to carry out 11 surveys only in the past 5 years, which is partly related to resources, and clearly we need to advocate much more strongly for countries to come on board and carry out these surveys, because they are the basis for advocacy, they are the basis for program development, and eventually for more effective action to address NTDs. Our region, starting from the beginning of the process of adopting the Framework Convention on Tobacco Control, has been one of the most enthusiastic and active in adopting the FCTC. We have also made progress in implementing it, and countries have developed legislation, regulations, and put in place multi-sectoral mechanisms for controlling tobacco use in countries. I'd just like to highlight the issue of mental health, which we all know is an area which among non-communicable diseases is among the most underfunded, and where access to services is the biggest challenge. And we recognize that people with mental disorders are among the most vulnerable, sometimes the most impoverished, and frankly also the most neglected as far as their health needs for this problem is concerned. We also know that the mental health workforce in most countries is seriously inadequate. We don't have enough specialists, psychiatrists. There are not enough doctors who are trained in mental health. Therefore, the provision of services is also extremely limited. So we have worked with countries to promote an approach of integrating mental health care into primary health care by training non-specialist care providers in a number of countries. This is a strategy on which we are expecting to build so that we have better access to services for mental health. In category 3, I think it's extremely exciting that we're starting to see some of the impacts of immunization as a tool, but immunization combined with other interventions. We have observed in 7 countries substantial declines in illness, mainly diarrhea, following vaccination of children against rotavirus when it is combined with improved water quality, sanitation, and hygiene, meaning that we're starting to see the benefit of immunization as a powerful public health tool, and also of combining different interventions to have real impact on health. Routine inclusion of pneumococcal conjugate and rotavirus vaccine is now done in 38 countries for pneumococcus and 31 countries for rotavirus. So this addition of these new vaccines is progressing in the region. As far as meningitis is concerned, we are very pleased that intermittent mass immunization campaigns against meningitis A have resulted in over 48 million people being vaccinated, and we've had very few cases of meningitis due to meningococcus A in 2016-2017. We have, of course, seen outbreaks due to other subtypes of meningitis, and there is work ongoing to see if it's possible to develop or to accelerate the development of a conjugate vaccine. I'd already mentioned this morning the fact that a significant milestone was reached when the heads of state adopted a declaration on immunization, which forms the basis for several things to happen, including increased domestic investment in immunization, which is an extremely valuable and powerful tool for public health. And we're already working with parliamentarians and with ministers of finance to advocate for this to become the case so that we improve our immunization programs. Next slide. I think I'll start here with the good news, which is shown in that multicolored column on the right side of the graph, which shows that African countries are progressing as far as HPV vaccination for the prevention of cervical cancer is concerned. So the number of girls that have been vaccinated with support from a range of partners, from WHO, from other partners, has increased to 6.4 million girls in 2012. We have 7 countries that built from the start of a pilot project to nationwide coverage, and they are listed there. And 23 countries have started, additional countries have started HPV demonstration vaccination program. So we are taking on board this, again, powerful prevention tool for the #1 cancer that is killing women in Africa, in the African region. We do acknowledge that our region has the lowest family planning coverage compared to other regions, which stands at 28%, and also a high maternal mortality ratio of 542 per 100,000 live births, which implies that significant efforts are required to reach the STD targets in relation to this. So we have disseminated new family planning guidelines and mobilized resources to support family planning programs and work with other partners, particularly UNFPA, to improve access to contraceptive services. Just to highlight this, to say that at an average of 116 per 1,000 girls aged 15 to 19 years, our region has the highest birth rate among adolescent girls in the world. So that is a real gap on which we need collectively to focus. And we have decided in the regional office to pursue a flagship program on adolescent health to help our countries bridge some of these gaps, and to also test our work on universal health coverage. If we can manage to deliver services for adolescents, particularly for adolescent girls, that will help us to understand that our health services are indeed improving and being able to deliver. As far as nutrition is concerned, we have worked to improve nutrition surveillance capacity in 11 countries through a project that we have, so that key nutrition indicators are included in the health information systems, and countries will be better able to monitor the nutritional status, which is important for overall health. Next slide. As far as Category 4 health system strengthening is concerned, We organized in Namibia late last year, the first regional technical forum on health system strengthening focused on universal health coverage. And coming out of this is a new action framework on integrating health systems strengthening, which we are promoting to be used by countries. Other work that has been achieved in our health systems area is improving regulatory capacity, in fact, for medicines, for vaccines in countries, and also improving the capacity for quality assurance of medical products. We are working on antimicrobial resistance between two programs, our health systems group and also the group dealing with outbreaks and emergencies, and we've started supporting countries to develop their plans to address antimicrobial resistance. Next slide, please. Much of the work that we've done in health system strengthening has been to help countries to generate data in the different building blocks of a functioning health system to enable action. So this slide is largely to show examples of that. We've worked with regional partners to implement the technical strategy on improving mortality statistics in Africa, organized through regional workshops to integrate cause of death, vital statistics, data collection into health facilities, and to strengthen the links with civil registration and country statistics systems. It's only on the basis of this that we'll be able to calculate the health outcomes, mortality, etc., which are the basis on which we made strategic decisions about health interventions. 8 countries were supported to develop national health observatories with universal health coverage indicators now included in the country profiles. So we are able now to start to track how countries are performing as far as the key components of universal health coverage is concerned, and that will enable us then to monitor as we go forward into the next period. We have other types of databases established. I won't go into detail. It's shown on the slide just to highlight that we're also supporting work to monitor what is going on with human resources, which is one of the building blocks of health systems in which we face the greatest challenges in our region. Next. On category 5, dealing with outbreaks and public health emergencies, we experience in the region a large number of public health events of different levels of severity. It's estimated that in a year or so we are dealing with 100, 150 events which are graded at different levels of severity, including public health events of international concerns. Work has been done to improve the capacity of laboratories to diagnose and confirm outbreaks through a process of networking laboratory capacity. We recognize that not every country has the laboratory capacity required. We have reference centers that serve as sub-regional or specialized reference centers for certain pathogens. And over 80% of our acute public health events were laboratory confirmed through this functional regional laboratory networks in 2016. Through our reform program, which I mentioned earlier this morning, we are putting in place now an incident management system of responding to public health events. And we've noticed that it is making our work in response much more effective, much more efficient, and very much more structured, so that the role of different actors, including our own staff, working, of course, with national systems, is clearly defined. We've supported 23 countries to conduct outbreak risk profiling mapping so that they can look forward and predict what type of risks they face as far as outbreaks are concerned. This is a contribution to preparedness. 15 countries have established emergency operations centers. This is not work that only WHO has supported, but we work closely with these emergency operations centers. So this is really work that is collectively carried out, achievements by member states and WHO working with other partners. We have had 14 countries carry out simulations using WHO tools. This is one of the key steps in testing the capacities of countries. And we have mobilized and trained 180 technical experts from 29 countries in response to outbreaks in different components. So I would say that the new program is working between the country, regional and global levels in a very different way, in a very flexible way, in a much more rapid way, where we are pooling our technical resources, and we're starting to see positive signs that this is working better than has been in the past. In category 6, which is the enabling function, we have carried out strategic engagement with our stakeholders, with member states, of course, including visits to countries, engagement with heads of state, advocating for health to be prioritized, advocating for certain health actions to be undertaken. And I was very encouraged by the receptiveness of our political leaders in terms of prioritizing health better. We improved our collaboration with the African Union Commission. We've already mentioned that this morning. And I'm just mentioning some of the partnerships that we are building on at the sub-regional level. At the regional level, the HHA refers to the Harmonization for Health in Africa mechanism, which is a partnership with UN agencies and bilateral agencies who work at the regional level. We work together to harmonize the way in which we are supporting health development in countries. We just renewed that partnership. We established a couple of mechanisms to get strategic advice from independent experts on health, including an independent advisory group who tell us quite frankly where we are doing well, where we are failing, and this group includes some of WHO's fiercest critics who are very open in letting us know what is their advice in order for us to do better, to serve our member states better. We carried out, as I said earlier, an evaluation of our transformation agenda, on which you will be provided with some information. And then we have put a lot of emphasis on improving our management and administration of our programs, including the resources that you entrust to our care and our use. We have seen an improvement in our audit results because we have followed closely with a compliance team on how we are managing our risks and our compliance. We have improved in reporting on money that is advanced to, we're having a problem with the slides, that is advanced to implementers, including ministries of health. So I thank you, ministers of health, and your teams for also improving the way in which you are reporting on the advances that WHO gives to you. We are seeing a better picture of reporting on what we call DFC, advances to implementers. We put in place key performance indicators, both for management and for programs, and we are seeing improvement on the management side because every 3 months we publish a scorecard comparing all our budget centers and showing which countries are doing well and which are not. And believe me, this is stimulating our WHO representatives and team members to make the extra effort to perform better. And we have started using programmatic key performance indicators because we have a big focus on results. We would like all the work that we are doing to show that we are delivering results. Not only are we engaging in processes, organizing meetings, going on missions, paying for consultants, at the end of the day we need to show that all this investment in time and money is delivering the result that we set out to deliver in our work plan, and we are increasingly managing for this purpose. We've improved our procurement processes, and we think that this is going to save us money, make us more efficient, so that our funding goes longer. And we have started, this is very exciting for us now, much of the work that we've been doing in the reform has been at the regional level. We have just embarked on a process of reviewing the structure and staffing of our country offices and trying to see what is and based on objective evidence, disease burden, capacity of a health system, availability of partners to work with the ministry and with the country to advance certain health agendas, to try to see what can be the particular contribution of WHO, and therefore what sort of staffing, what size of office does WHO need in a specific country. We've just carried out some pilots and have emerged with some very interesting results which show that we can do better in terms of our staffing being more relevant. We need to mobilize some additional resources, but there are areas in which we can also sunset having staff, because we know that other partners are supporting the countries to carry out those program areas. So, for example, I was very interested to see that one of the recurring recommendations is that we carry out a life course approach for preventing maternal, child, adolescent health interventions, as well as for non-communicable diseases. So we have some suggestions in a couple of countries to combine those functions in one team. So we're still analyzing if that makes sense or not, but it might be that we find a more rational way of organizing our staffing than not simply following the structure of the country program, and therefore could be more effective in supporting ministries and countries with fewer resources. So to conclude, I'd like to reiterate that working with you, ministers, and your teams, and with other partners, we have made some key achievements during the reporting period. We've improved our outbreak response. We have made some progress in defining better how to work on improving health systems in countries. We've developed some tools, and we have made progress also in ending some of the priority diseases which are the main disease burden in our region. We see the SDGs as a big opportunity, as I said. We also see the vision of the new Director General. The DG mentioned earlier that we are developing the next general program of work as the opportunity then to focus on certain priorities and to work with you to advance those in the region. We do think that it's critical to address non-communicable diseases, and since we are not expecting to have a global fund on this, we see two ways to approach this mainly. Integrating into health promotion and work to affect the social determinants of health for prevention, and then through universal health coverage, integrating into service delivery, particularly at the local and at the district level, into primary health care. We recognize that we need to do much more work in mobilizing resources, in showing results for our work, and in being an obvious good investment for partners. And we are very grateful that the 3% increase in assessed contribution was agreed by the World Health Assembly. We hope to continue to work with member states to advocate for additional flexible resources, but we're also, as I said, going to work on broadening the base of resource mobilization and our donors in the region. And then finally, we will continue to work on the transformation agenda, very much at the country level, integrating it so that at the end of the day, you see at the country level that a WHO that is more focused on results, that is more efficient in the use of the resources that we have, that is staffed more appropriately, where more of our capacity is focused at the country level, is a better partner in supporting what you are doing to improve the health of your populations. And we look forward to working with you in taking this into the future. Thank you very much.
Thank you, Dr. Moeti. You will agree with me that it's really an extensive coverage of what has been happening in the regional office and overflowing into our individual countries. And pertinently, she has covered the issues of contributions in terms of the budget, the assessed contributions. I hope I'm glad, Dr. Moeti, everybody was really listening in spite of the heavy lunch. They were really listening. And the issue of the 82% voluntary contributions. But she emphasized that the budget was thinly spread, and therefore there must be prioritization. And I liked that you talked about budget monitoring and the mechanisms to put in place to monitor our budgets. And the poor funding on NCDs. But you see, the issue of co-infection with HIV and TB has been highlighted, and it really impacts on in terms of what you achieve in country. I was was pleased about the category 3, where you talked about immunizations as very, very key, and the declaration of immunization by our heads of state. But you mentioned the cancer of the cervix, especially HPV vaccination of girls. I hope when we contribute, we can highlight these areas. How far have we done with HPV vaccination in our own individual countries? And the issue of low family planning coverage, which also gives us the highest birth rate in Africa, and what we are doing about that. And the issue of food fortification as implied by nutrition surveillance. Are we doing any food fortification in our countries? Health system strengthening. And to strengthen health systems, you must strengthen the data collection. And that's really very aptly put. The issue of public health emergencies, you highlighted that, and how you will then go into incident management systems. I would like to see that a little bit more, or to be expanded. And the enabling environment, or the enabling function, the HHA, I hope you were all listening, which gives us the performance indicators, and how the country offices are going to do functional reviews. I think I'm glad Director General and the Deputy Director, I want to recognize Asoma Abo, who is here. Thank you very much for being here. I was pleased to see him. The last time I saw him, obviously, he was going up the lift in Geneva, somewhere in the Geneva offices. So it's good to see you here in Zimbabwe. So, ladies and gentlemen, I would like at this juncture to recall an earlier decision of the Executive Board stating that WHO needs more guidance and orientation from the governing bodies, which is us here. So your contributions should therefore focus on providing the necessary guidance and orientation to the Secretariat in relation to the document presented. I know I used to do it too. I've been Minister of Health for a long time. Instead of focusing on what has been given, I read my own country report and talk about what I've done in Murewa, and then not focus on the relevant document. For effective use of our time available during this session, please try to be brief so that we can have contributions from as many speakers as possible. And let me just emphasize that I have already conveyed your congratulations, so we can graciously skip that part and go straight into your comments. The floor is now open for comments on the regional directors' presentations, and I'll invite comments from the floor from the ministers and the heads of delegation. I notice United Republic of Tanzania. Can somebody assist me to pick out who have put up their cards? Put up your card, perhaps push it up so we can see you immediately. So far, it's only Tanzania that I've noticed. Anybody else? Cameroon? Cameroon? Anybody else? Is it Congo? Is it Congo? Comoros or Congo? Yes, Congo. Angola. Botswana. So far, it will be United Republic of Tanzania, followed by Cameroon, then Congo, then Angola, then Botswana. So can we start with the United Republic of Tanzania? You have the floor.
Thank you, Mr. Chairman. Excuse me. Tanzania takes note of the biannual report of the Regional Director on the work of WHO in the Africa region for the period 2016-2017. We commend the Regional Director on the quality of the report, which has provided a comprehensive overview of WHO's performance, including achievements and way forward. Our continent is facing various challenges in health as presented in the report, and the numerous interventions are in place to address them with support from different stakeholders, including WHO, of which is well appreciated by our governments. Mr. Chairperson, we commend the adoption of the framework on universal health coverage and the Sustainable Development Goals to guide countries in addressing health need of their population in a comprehensive and coordinated approach. We applaud the convening of the first ever Africa Health Forum themed Putting People First, the Road to Universal Health Coverage. We are convinced that implementing universal health coverage will facilitate more synergies and reduce fragmentations of interventions in our health delivery systems and reduce wastage of the limited resources, including time, at our disposal. We further note the need to address the environmental determinants for health, and we are supportive in promoting further multi-sectoral collaboration in addressing those determinants of health by working across the different sectors, as most of the challenges we face are beyond the health sector. WHO is more placed to facilitate this collaboration, and we call the regional office to do more in this particular aspect. Mr. Chairperson, in addressing the increase to resistance of microbial agents, we have noted the progress made in assisting countries to develop national plans to address the challenge. However, we are concerned that having plans is not enough for our continent. We urgently need to have country-specific updated baseline information on the magnitude of resistance to drugs in use for treating various health conditions besides malaria, tuberculosis, HIV/AIDS, so appropriate actions are taken in a timely basis. We recommend that as plans are being developed concurrently, countries be supported by different stakeholders to put in place a surveillance mechanism of monitoring drug resistance as the bugs are evolving faster than our responses. Mr. Chairperson, on the issue of vaccine, we have noted an increase in use of vaccine in our continent to address various diseases. However, we have observed with concern the issue of shortages of vaccines as it was presented in the report. Yellow fever vaccine and the inactivated polio vaccines, just to mention a few, which made countries to use fractional doses, while there is limited scientific evidence on its effectiveness in providing long-term immunity to those vaccinated. We further call for WHO AFRO to work closely with AU, which is also pursuing the continental plan of having the capacity to produce drugs to address vaccines. I thank you, Mr. Chairperson.
Thank you, Honorable Delegate from Tanzania. Cameroon, you have the floor.
Merci, Monsieur le Président. La délégation du Cameroun se félicite de la pertinence du train de mesures que Madame le directeur régional de l'OMS conduit si courageusement depuis sa prise de fonction dans le cadre de l'agenda dit de transformation. Il est en effet manifeste que ces mesures commencent à apporter des fruits probants, tels que l'atteste le rapport qu'elle vient de nous présenter. À cet égard, je voudrais témoigner qu'au Cameroun, nous percevons ces progrès à travers notamment, premièrement, une amélioration très notable du dialogue programmatique que nous avons avec le bureau local de l'OMS, se traduisant notamment par l'adoption récente d'un plan d'une stratégie de coopération avec l'OMS et l'élaboration d'un plan de travail biannuel. Deuxièmement, par l'amélioration de la performance du dispositif de suivi et de l'utilisation des fonds et des redditions des comptes des DFC notamment. Mon pays se réjouit ainsi que le contrôle de l'utilisation des fonds mobilisés par l'OMS qui a été effectué dernièrement par le bureau régional au Cameroun ait pu établir un niveau très satisfaisant, à peu près 96% des financements correctement utilisés et justifiés. Troisièmement, une présence plus effective de l'OMS sur le terrain grâce à la création de 3 sous-bureaux régionaux, sous-bureaux pays qui couvrent les 4 principales régions du pays. Au total, nous sommes satisfaits de la qualité du partenariat stratégique avec l'OMS et comptons sur le soutien continu de l'OMS pour le programme de couverture sanitaire universelle qui est en cours au Cameroun, la réflexion sur la pérennisation et la soutenabilité de financement pour la santé, l'introduction de nouveaux vaccins et de nouveaux produits et dispositifs de contraception pour la pour la planification familiale ainsi que pour la soutenabilité des financements. Et enfin, pour le renforcement de nos capacités en matière de dispositifs de détection, de riposte et de contrôle des épidémies et des pandémies. Je vous remercie, Monsieur le Président.
Thank you, Cameroon, for highlighting the issue of control of funding. And again, just like what Tanzania said about the vaccines, it's a big issue, the issue of vaccines. Yes, Congo, you have the floor.
Merci, Monsieur le Président. Le Congo se réjouit des activités menées pendant cette période du biennale et surtout du niveau de réalisation du budget. Il se réjouit également qu'en matière de maladies tropicales négligées, à travers le programme ESPEN, le financement ait pu être trouvé pour faire face à ces maladies. Mais nous constatons qu'au niveau des maladies non transmissibles, les financements n'ont pas été tangibles si on tient compte des engagements et des différentes réunions qui ont été de haut niveau qui ont été tenues pour essayer de mobiliser et les pays et les partenaires pour le financement de ces maladies. Ces maladies continuent toujours à peser lourd sur la santé des populations, maintenant et pour les prochaines années. Quelle approche pourront-on avoir pour essayer de mobiliser un peu plus de financement au niveau de ces maladies? Merci, Monsieur le Président.
Again, thank you very much, Congo, for highlighting the issue of funding, especially for the tropical neglected diseases and the NCDs. Angola, you have the floor.
Muito obrigado, Senhor Presidente. A Angola felicita a Diretora Regional da OMS pelo relatório apresentado e com agrado tomamos nota. Apreciamos a forma como foram abordadas as situações de emergência que ocorreram na região e a prontidão como foram debeladas as últimas epidemias do vírus de ébola, principalmente no último ano, tendo como base o programa para as emergências sanitárias. Aproveitamos a oportunidade para manifestar os agradecimentos pelo apoio recebido da comunidade internacional para o controle da epidemia de febre amarela que assolou o país de dezembro de 2015 a 23 de junho de 2016, em especial a OMS, pela criação do Sistema de Gestão de Incidentes e que facilitou o envolvimento e a coordenação de todos os parceiros na cooperação bilateral do Ministério da Saúde. Achamos que esta experiência foi de sucesso, pese embora a necessidade do seu reforço e melhoria diante de situações similares. Os sistemas de saúde no seu todo continuam a merecer a preocupação e o seu reforço torna-se cada vez mais necessário e urgente. Além disso, a sustentabilidade dos programas precisa ser assegurada com investimentos domésticos para aquisições e melhoria de qualidade das intervenções. No concerne ao VIH-Sida, Angola está consciente que o alcance das metas estabelecidas representa para o país um enorme desafio. Por um lado, a baixa cobertura do tratamento antirretroviral e, por outro lado, fatores como barreiras socioeconómicas e estruturais, assim como a garantia da sustentabilidade. Porém, para o cumprimento das metas, Angola concorre em ajustar as suas políticas e estratégias e impulsionar medidas destinadas a aumentar o tratamento de todas as pessoas que vivem com VIH e SIDA, assumindo e implementar a estratégia testar e tratar todos no presente semestre. Inicialmente na província de Luanda, estando em curso a finalização do plano de implementação para aceleração a nível nacional, bem como a mobilização de recursos, o reforço de gestão do estoque e a melhoria do sistema de informação. Os desafios para a região são enormes, porque continuamos a enfrentar doenças transmissíveis preveníveis que são comuns, acrescido do facto de haver um incremento de doenças não transmissíveis e outros decorrentes das alterações climáticas, além de acidentes de aviação que continuam a ceifar e a deixar incapacitadas populações jovens. Senhora Diretora Regional e Sr. Presidente, encorajamos a Diretora Regional da OMS a prosseguir com a agenda de transformação, tomando as iniciativas que visam melhorar a saúde de todos os Estados membros da região. Muito obrigado.
Thank you, Angola, for highlighting the health emergencies and how the funding should be sustainable. And of course, NCDs together with HIV. Botswana, you have the floor.
Thank you very much, Mr. Chairman. First, I'll start by thanking yourself and your government for the wonderful hospitality that we have received since we got here. But in terms of the report that we are talking about now, I think it was pretty comprehensive, and I'm quite happy with the achievements that have been highlighted by the regional director. But what I particularly like is that we are starting to talk a lot more, emphasize or focus on monitoring and evaluation on our budget allocation, thinking about sustainability. I think it is critical. And I think the fact that you are looking at internal efficiencies and transforming the office to be able to be in alignment with the needs of the continent, I think it is something that is worth commending, because that was pretty clear. If we look at the first category, Botswana, we introduced it all last year in June. But the greatest challenge that you are having, where perhaps we need to talk more about, is on the testing. We need to be thinking of innovative ways or other forms of, I don't know what really, but that seems to be the area of concern. And I don't think it's just a problem for Botswana, I think it's a problem for others too. So we need to revisit that and find other strategies that can assist. And category 2, I think we all recognize that we are dealing with a pandemic, but looking at the budget allocation, I think we need more money pumped towards that. If we take into account the vigorous and the energy that we put in other diseases, I think we need the same for NCDs, because if we don't do that, we're basically facing a running train that's coming towards us, and therefore we need to put more energy into that and more resources. And category 3, we as Botswana are very much committed to vaccinating our population, but I think I'm noting that much of it's perhaps funded for others, but we need more political will. I think we need more government resources to cover that space, rather than be heavily reliant on assistance, because prevention, like they say, is better than cure. In Botswana in particular, we introduced a few, and this was all a few vaccines, and this was largely funded by government. HPV was one of them, where we were able to vaccinate 90% of the young girls between the ages of 9 and 13, or 9 and 12, if I'm correct. Rotavirus was one of them, and but I think more and more government funding, and I'm saying this to colleagues, it can be debated, but I think we need to see more governments coming up and more political will in that regard than perhaps we are seeing right now. All in all, I'm quite happy with the report, and I think it is commendable effort by the regional director, so well done.
Well, thank you, Botswana. Yeah, political will is actually commitment to financing, and that's what we should really be now aiming at, not just the political will of verbal declarations. And I agree, energy into NCDs, and it's pleasing that the office is transforming itself to be more efficient in WHO. Is there any more contributions from the floor? If none, then I will now give the floor. South Africa. Oh, sorry, Dr. Motsoaledi.
Thank you very much, Chairperson. I am painfully aware of the fact that you said we have done salutations already, and we should repeat them. But please bear with me. I wish to convey our condolences to Sierra Leone, who happen to be my neighbors here, for what they've just experienced. recently. Our heartfelt condolences to them, and I hope maybe when time permits, I suppose there might be a discussion here on how we're going to help. I'm aware that at AU level, countries are already helping, including my country. But I just thought it would be very appropriate. On the comments, Chairperson, of the report, which was quite substantial, I wish to thank the Regional Director for this comprehensive biennial report. It's actually gratifying that the report speaks to building blocks of health systems and reflects on the work in areas of national health, financing, human resources for health, universal health coverage, and sustainable development goals. Our continent should lead on the progress towards universal health coverage, Chairperson, and strengthening of healthcare system. I once uttered a statement which might be regarded as very controversial, but I'm going to repeat it every time we meet as Africa. We are the only continent in the whole planet where when our heads of states are sick, they have to go to other continents for treatment. Chairperson, this must come to an end. Yes, it must come to an end. We must plan our healthcare system in such a way that it can treat anybody. That's the only time we continent. That is the first thing I want to say. The second thing, Chairperson, I'm sure you are aware that I'm also presently serving as the Chairperson of the Stop TB Partnership. And I am happy that the report also flagged on TB. But I have to mention, Chairperson, that despite the fact that over the past 200 years, TB has killed more people than HIV/AIDS itself, than malaria, polio, influenza, Ebola, bubonic plague, and cholera, all of them added together. And today is #1 killer of all infectious diseases. But our response to it is not as it should be. And I also want to flag this to the regional office that we need to do something about TB. It killed 1.5 million people last year. In my country alone, it's killing 40,000 people per annum. That's the biggest killer. But because it is not dramatic, it's not very much on our radar screens. In this regard, I also want to add this new threat, which has even shaken the West, on antimicrobial resistance. We're not going to win it on the African continent if we can't win the battle against TB, for the simple reason that 1/3 of the burden of all antimicrobial resistance is caused by multi-drug resistant TB. If you have already failed in 1/3, you are remain with only 2/3 of the battle to win. So we can't win by fighting only 2/3 of the battle. I was very lucky to attend the G20 Health Ministers meeting, which was held in Berlin in May, just before the World Health Assembly. And the declaration adopted there, I quote, to address tuberculosis within interventions for antimicrobial resistance. We acknowledge the need to develop and promote access to new drugs, diagnostics, and vaccines to tackle drug-resistant tuberculosis, consistent with the WHO and TB strategy, close quotes. The last thing I want to mention, Chairperson, the NDCs, the non-communicable diseases, NCDs, I mean to say. Chairperson, we are aware that this is a new pandemic in our continent. Africa is known for communicable disease, especially HIV/AIDS and TB, as I've said, malaria, polio, and many others, diseases which are on our program. How then can we fold our arms? to afford another wave of pandemics. How are we going to survive the pandemics of non-communicable diseases like high blood pressure, cancer, diabetes, and chronic lung diseases like asthma? We simply cannot afford. And I will propose, Chairperson, that we aggressively need to nip this in the bud. We all know what to do, and I'm happy to mention this in front of the Director General of the World Organization and the Regional Director. I think, Chairperson, we are not brave enough. Honestly, we know that the biggest problem of NCDs, because there's no virus here, there's no bacteria, is human beings. And it's mostly industry. We know that very well. Yes, it's alcohol, it's tobacco, it's diet, especially sugar. There is sugar poisoning now in the world. And we know the people who poison us, but we are scared to tackle them head on. Yes. We're scared to tackle them head on. Chairperson, Coca-Cola is moving with their eyes closed in our countries and poison everybody arrogantly. And we're doing nothing. In South Africa, we tried on the issue of sugar tax. Yes, I know, because there is something called state capture in our country, in my country. And I suspect you are being captured here without noticing it. No, we need to stand up. And the weapon used is job creation. In other words, people are telling us, please allow us to poison your people, we'll give you jobs. And this strategy of job creation is working so much. Regional Director, let me warn you. Even the Framework Convention on Tobacco Control, which was largely successful, is now being attacked. It's now being attacked on the issue of job creation. People are already being told how many jobs will be created in South Africa if we reverse all our anti-tobacco legislation. So I'm just saying, if we don't open up, we're going to be in trouble. I was very scared when I met the Minister of Health in China, because I thought China is very strong to withstand these things, when she was telling me Coca-Cola is destroying their country. So it's destroying all our countries. Not a single resolution is being passed. It's what I call sugar poisoning. Because you check cancer, you check diabetes, you check high blood pressure, sugar is playing a role. When are we going to correct it? We don't have the money to treat. Like the developed country, there's no money to treat our people. The only thing we can do is to prevent and prevent and prevent. And you can't prevent if you are not brave to stop those who are causing this problem. So I'll propose that we put this on the agenda and address them regardless of the consequences. On the issue of vaccines, Chairperson, I'm very happy we know vaccination and prevention go together. Is one and the same thing, and I want us to strengthen it. While you said we must not report our countries, Chairperson, I am tended to mention to you that on HPV, in South Africa, we have already vaccinated 1.4 million school girls over a period of 3 years. Out of the 6 million put there, 1.5 million is contributed by us. I'm saying so because we are very proud. We must encourage each other. Girls in this continent, or women in this continent, have died enough of breast cancer and cervical cancer, and now that there's a vaccine, at least we can stop cervical cancer. Thank you very much.
Thank you, South Africa, for that passion. And indeed, I hope that we will get a bit of a brief at some stage from Sierra Leone about the mudslide that has happened there. But you mentioned passionately about universal health coverage in relation to health system strengthening. And we really need to strengthen our continental health system so that we don't get this tourism, outside health tourism or medical tourism out of our countries. TB is underestimated, and it is true that it's #1 killer. And you rightly say that the Director General is here and he's absorbing this. Yes, we need to be brave about Coca-Cola. We need bravery about NCDs. It's a real pandemic. So, yes, thank you very much for really mentioning this. And I'm glad about HPV vaccine that you are doing in South Africa. That's really what will help us. So I will now. Is there another contribution? Is there anybody I've missed? Burundi and Niger.
Also in Nigeria.
Is it Nigeria? Nigeria.
Merci de me passer la parole. Le Burundi félicite la directrice régionale pour sa présentation et se réjouit des résultats atteints, puisque c'est la toute première réunion de la région africaine de l'OMS où nous avons la présence effective du nouveau directeur général de l'OMS. Le Burundi ne peut pas s'empêcher de le féliciter pour sa brillante élection au poste du directeur général. Je remercie les prédécesseurs pour les questions très pertinentes qu'ils ont soulevées et qui doivent attirer l'attention de la coordination de l'OMS Afro. Après avoir suivi la présentation de la directrice régionale, et une petite préoccupation, c'est au sujet de la mise en œuvre du règlement sanitaire international dans les pays membres de l'OMS Afro. Je voudrais que l'OMS Afro en assure le suivi et au besoin fasse des appuis techniques et financiers pour l'application du règlement sanitaire international au niveau de tous les pays membres de l'OMS Afro. Je vous remercie.
Thank you, Burundi, for highlighting the IHR. Is it Nigeria? You have the floor.
Thank you, Mr. Chairman. We want to express appreciation to the World Health Organization for the support provided during the last meningitis outbreak and also the support we are getting for the current Lassa fever situation we have, and also for the emergence of polio cases in the northeast, where we are getting a lot of support to the national structures. We hope that there will be more coordinated activities in the polio region around the Lake Chad Basin. Unfortunately, there is still a lot of insecurity in that area, and we are hoping that there are no pockets of areas that have not yet been uncovered where children have never received any immunization. We support the renewed focus on coordinated response to public health emergencies and offer cooperation in developing these structures for the country and for the entire region. Nigeria has the political will and the commitment towards universal health coverage and achievement of the SDG goals. We need to conduct surveys on NCDs, following on very passionate plea made by the South African minister just now, which we support, in order to understand the burden of disease and the threat caused by increased consumption of sugar and also some inordinate consumption of salt. And of course, in Nigeria, the problems we have with the Niger Delta due to a lot of pollution of the environment by hydrocarbons and also the air. Thank you very much.
Yep, thank you, Nigeria, for again highlighting NCDs and health emergencies and the issue of polio. Are there any further comments from ministers and heads of delegation? If no further comments, I will now give the floor to Dr. Moeti for her comments on the comments that have been given.
Okay. Thank you very much, Chair, and thank you, Honorable Ministers and delegates, for your comments, contributions, suggestions, and even instructions to your Secretariat. So we very much appreciate the sharing of your thinking and your perspectives and the advice that you are giving I think not only to the Secretariat, but to the region, to the regional committee on some of the proposals that have been suggested. I'll just refer specifically to several of the comments. First of all, to the Honorable Delegate from Tanzania, Honorable Minister from Tanzania. Yes, indeed, it is critical. It will be very important to actually know what is going on with antibiotic resistance in countries. The plans were the first step. Within that, clearly, is an intention to work on this aspect as well. But I agree with you that while we are getting a whole plan funded, we may as well get started with some of the most critical areas. And yesterday, as I said, we were at, I attended a meeting of the board of the Africa CDC, where they were highlighting with great enthusiasm having proposed or put in place a surveillance network that is also going to get involved in surveillance of AMR. So I agree very much that we need to get going on this. As WHO, this is part of what we are going to be supporting in countries. As far as vaccine shortages are concerned, you are correct. Again, we did have and continue to have challenges in having access to yellow fever vaccine, especially when we were supporting the response to the outbreaks in Angola and the DRC. I'm pleased to say that following that, and perhaps having slightly preceded that, there is an initiative being started with Gavi, with other partners, on the elimination of yellow fever epidemics, which includes working on ensuring that sufficient quantities of yellow fever vaccine are produced to enable work for preventive campaigns in East and Central Africa, so that we start to have a situation where we reduce yellow fever outbreaks. I'd like to thank the delegate from Cameroon for having pointed out some ways in which some of the changes that we are making are starting to be reflected in more effective support for the country, including, as you pointed out, being more present in the field where it's necessary through sub-offices. I mean, these are some of the things that we are considering over more countries in the region. We've recognized that sometimes it's not enough to operate from a capital and to be taking people out on missions. We do have sub-offices in a number of countries, and this is something that we'll continue to explore if the resources allow it and if the needs really are there. So thank you for that encouragement. The issue of NCDs was highlighted, particularly, I think, two things. One, the resource challenges around NCDs, and then secondly, very passionately by the South African minister, really some of the underlying factors, what is driving what is going on in NCDs. As far as funding is concerned, I remember when I was the director of the NCD cluster in the regional office a few years ago, there was a buzz at that time about a possible global fund for NCDs, when there was a great deal of discussion at the level of the United Nations. So this has not materialized, and we can debate whether this is a good or a bad thing. But I think it compels us then to look for other ways of financing work on NCDs. Clearly, we will need to make concerted efforts to make the investment case on NCDs, which actually I think is just a matter of needing to sit down, put data together, and put this together, because it's very clear that if we invest in prevention, we will avoid the lifelong treatment costs that countries, individuals, households have to embark on when people have NCDs, and that we will also avoid many other costs, indirect costs of people being ill with NCDs. So in the region, we've recognized that resource mobilization is one of our biggest challenges, not only for our own work as Secretariat, but also for the area of NCDs in general. This is an area which has got partners in two groups. We get disease-specific groups. There are people who are working on cancer, on cardiovascular diseases, but we don't have among them very large groups or perhaps foundations and others that are financing NCDs. Clearly, we will need to look to do much more work to make the case, to interest some of the partners that are interested in global health, public health in NCDs, working with you. We also think that we could make more progress if we focused on integration of the needs of NCDs into health systems, particularly at the primary care level. And WHO has developed some tools for this. There's something called HUPEN. There's a whole strategy that is focused on ensuring that the human resources aspects, the data aspects, the medicines aspects can be integrated into ongoing improvement of health systems. I have to say, as your secretariat, we have to start to model this ourselves in the way that we are working on NCDs. We are starting to make the effort so that we can develop the tools necessary to make sure that this is going on and can be integrated at district level, at local level, and into the national health budget in an efficient way. And as I said earlier on, we think that if we focus very much on the prevention aspects, and here I'd like to really thank the Minister of South Africa for very passionately and strongly reiterating what is going on with NCDs as far as the determinants and the driving force of NCDs. We did work very strongly, I agree, a number of years ago on tobacco, and some of this work is ongoing. And we observe that the response, the pushback of the tobacco industry continues up to today, even in developed countries. Even as countries are putting in place mechanisms, there are still court cases going where the evidence on tobacco is still being challenged. Certainly in the alcohol area, I believe the industry learned the experience of tobacco and is very much more prepared, empowered, and funded to carry out this work. So, as your secretariat will think about how to be more brave, as you put it, and how to work with member states to be more explicit in addressing the industry interventions, which include, when we have seen this in our region, which has included influencing the development of national policies, influencing the adoption or not of legislation in parliaments in countries, funding certain foundations that are related to very influential individuals in countries, all of which serves to retard and impede some of the key public policies that need to be made in order to address NCDs, including the issue of taxation, not only for tobacco but for alcohol as well, and as you were saying, the sugar tax. So we will put much more effort on this, and we hope to find some response and reciprocities on your part as member states to take on these approaches, which are extremely challenging because of the imbalance in the resourcing. And thank you for I think you also made a point about being reliant on international funding for immunization. I'd just like to highlight that it is a fact that when countries are transitioning from Gavi funding because they are transitioning economically, we do observe significant challenges in managing that process so that we don't get gaps and delays in countries being able to make their contributions. So clearly here there is work that we need to do together to improve the management of those transition processes. And we also note, unfortunately, that we have a few middle or even upper income countries in our region where the immunization coverage rates are very much lower than countries which have lower economic status. So we need to work to see what needs to happen to ensure the right advocacy in these kind of contexts for the appropriate financing for immunization, which needs to be sustained and expanded. We note your emphasis on tuberculosis, Minister Motsoaledi, and also the fact that this needs to be emphasized, reiterated, and integrated into the work on AMR. We are starting to work like that in the Secretariat. Just finally, on the comment from Burundi, we are indeed working with countries. Nous travaillons avec les pays pour essayer d'appuyer les RSI. Je crois que nous pouvons voir avec vous et notre bureau pays et notre représentant pour le Burundi qui heureusement est ici pour voir comment nous pouvons mieux vous appuyer. Il y a tout un processus d'une initiative sur la sécurité sanitaire au niveau global où il y a l'OMS joue un rôle plutôt technique. Nous appuyons techniquement. Et il y a d'autres partenaires qui ont proposé de did work very much with you on some of these outbreaks and on the Lake Chad process. I think we need to accept that there are areas where we have great difficulties in having access to populations. So this causes challenges both with surveillance and also with being able to carry out campaigns to control polio in those areas. But as you are aware, Minister, we are working with the partners around the Lake Chad mechanism very much to work with the security authorities and those who manage security to try to find opportunities now and again to have access to populations for both AFP surveillance, for environmental surveillance, and to be able to carry out interventions. We are simply having to learn how to carry out public health functions in areas of great insecurity where the situation changes all the time, and we have some innovations where we involve people at the community level who can also intervene to enable better access. But this is an area on which we need to continue to work together. You did say that we need to do more work to conduct surveys on NCDs. We are trying. We do not have the resources available, frankly, in WHO currently to do more than the STEP surveys. There are some global surveys among young people, among school-going people on the risk factors mainly. We have also made an attempt in the African region to integrate NCD surveillance into ongoing disease surveillance. Of course, much of our disease surveillance is about acute events, outbreaks, and communicable diseases, and we need to explore ways of linking these two systems so that we can be better able to gather data on NCDs. I think you mentioned also environmental issues, pollution. This is an area on which we are needing to work more. With UNEP, the United Nations Environmental Programme, we are proposing to organize a follow-up ministerial meeting on health and environment. And not that this is going to necessarily result in interventions immediately, but we are working. There is an initiative that we have with UNEP to try to manage environmental factors and their impact on health, which again needs us to mobilize additional resources, and we will see how to work with you with a particular focus on the issue that you have mentioned. Thank you very much, Chair.
Well, thank you very much, Regional Director. My watch says we should be having tea because we're supposed to come back here at 4:30 for the final session, but we're fortunate that we've got Dr. Gebreyesus Tadros here, and we really want to take advantage of his presence. Maybe you may want to make a few comments.
Yeah, thank you, Chair. I will focus on some of the issues. Number one, I agree with Dr. Moeti that we should move from process-based into result-oriented approach. We should try to see or measure impact. When I discussed with my colleagues at the headquarters, one challenge that I saw was that we don't plan based on impact, results, saved lives, and also access. We plan based on process. And when you measure it, that's what you get. So Afro is moving away from that. When I asked them, they told me that Afro has started something, and I said, okay, why not we check what Afro started? And it's exactly what I was proposing to the headquarters. So I think making the organization both at the regional level and headquarters result-oriented is very important. And I salute my sister for the initiative. I think this will be a time when headquarters can learn from the region. So we're documenting that. Then the second is on antimicrobial resistance. I agree with Aaron, my brother. Especially TB should be given a serious attention. And I know what he was saying. He didn't want to mention names, but there was conflict between some people who were involved in especially the listing of the pathogens on antimicrobial resistance list. And that problem is now resolved. Maybe your colleagues have, people from the partnership has reported to you. TB more attention. It's a serious issue. I cannot stress it more. It's serious, as you rightly said, and it should be given a serious attention. A very old scourge, but it's actually the most dangerous one still, the most dangerous one. Then on vaccine fractional use, as you have rightly suggested, we need to look at it. Of course, the result was good from the field, but I think checking on that, especially having better evidence to see if the fractional use is okay or not, I think we have to make sure that that's properly documented. And then on emergency response and sustainable financing, it's a very important issue. We're working on that at the headquarters level. When Ebola struck, I think the whole world was nervous and in fear. But after it's over, then people are relaxing and forgot even that there was a problem. So even pledges that were made before are not coming. So that's the problem. So we had a discussion with the World Bank to address this problem, and they have started actually health emergency response insurance program for emergencies that can avail around $450 million US. We had a discussion last week in Geneva, so we will study that program, but it's already up and running for the next 3 years. But based on our experience in the next 3 years, we will see what we can do. But there is already a good program from the World Bank that WHO is going to work with very closely. I would like to thank actually the World Bank using this opportunity for their very innovative ideas and also for the excellent discussion we had last week. And then on NCDs, I fully agree again with Aaron and other speakers. I think we have to take it seriously. We cannot treat when people have non-communicable diseases. It's true, we don't have the money. It's better to focus on prevention. And there are many good models. For sugar, for instance, we can learn from Mexico. Tobacco, we can learn from Uruguay. But one thing I suggest is on non-communicable diseases, in addition to what Dr. Meiti said, we have to take it to the African Union. And there should be a serious debate. For instance, on the protocol for illicit financing, Africa had done more, but still is not enough. More countries, in terms of proportion, have ratified the elimination of illicit financing, the protocol, but still is not enough. I think the whole continent should endorse it and should also enforce it properly. So taking it to African Union and debate would be important, be it the sugar, tobacco, alcohol, or the physical activity. Of course, as Dr. Moeti said, instead of splitting it into different fragments, I think we need to push as a package. We know the risk factors and we know how to tackle them, and tackling them and the prevention part is very, very cheap. So we have to focus on that's the most cost effective. And we have to fight the industries, as he had rightly said, to save lives. We cannot really compromise because this is a matter of life and death. And it cannot be really stressed more than Aaron said. Actually, he had said it all, but we have to take it to our political leaders. And if there is anything we can help, we would be happy to help in any way possible. Then final, when we talk about NCDs, I think it's really important we link mental health. It's really neglected, and the stigma is there. It's incredible. We focus, to fight mental health, we focus on big institutions like hospitals and so on. Consider the mentally ill as a criminal. I think we have to get out of that. We have to mainstream the services in all our health institutions, up to the front line, up to the health centers, health posts. Not only that, we have to take it to the community, and we have to take it to the family. Families should also take responsibility. I think mental health is very important, and which is really affecting millions, but also one of the neglected, like the neglected tropical diseases that we have to also focus, because we're making good progress to eliminate some of them. I think investment on that will also be important. Thank you so much for this opportunity, but I really congratulate you for the very concrete recommendations and so on that you have already put forward. Thank you.
Yep. Yes, thank you, Dr. Moeti and Dr. Gebreyesus. I think that you really have covered us well. We were supposed to have gone for tea at 4 o'clock and come back at 4:30. But knowing us, we need that tea because the last session is a very important session. We can't afford to really, we need to do this. So I suggest, and I want to thank you doctors, to the two doctors, we've completed the discussion of the report, and bearing in mind all comments and suggestions made, can we now consider that the committee is ready to take note of the report of the regional director? Are we ready to take note? Yeah, seeing that there's no objection, we take note. So we'll now break for a 20-minute tea break, and we come back at exactly 5, 10, 15, quarter to. So just go out, empty your bladders if you have to, then come back. Thank you.